Hello, I am Marc Humbert from the University of South Paris, section editor of the European Respiratory Journal in charge of pulmonary vascular medicine. This month, the ERJ is very proud to publish the proceedings of the Sixth World Symposium on Pulmonary Hypertension. For the first time, these 13 chapters are available open access, and I would like to thank very much the editors of the Sixth World Symposium on Pulmonary Hypertension, namely Professor Nazzareno Galiè, Professor Valerie McLaughlin, Professor Louis Rubin, and Professor Gérald Simoneau for this very important decision. Today, I'm delighted to briefly discuss these proceedings with Professor Nazzareno Galiè, who is a professor of cardiology at the University of Bologna in Italy. Hello, Nazzareno. Thanks very much for joining us today.
Thanks for the invitation to have this discussion, because I think it's very important to have a comment to this event, to these 13 articles summarizing the state of the art of pulmonary hypertension.
Thank you, Nazzareno. So to start with a historical question, can you briefly summarize the history and the objectives of the World Symposium on Pulmonary Hypertension?
Yes, this is an history of 45 years. In fact, in 1973, there was the first meeting at the WHO site in Geneva, trying to focus on an epidemic of pulmonary hypertension due to anorexigen. And at that time, the first definition of pulmonary hypertension was proposed. 25 years later, in 1998, in Evian, the second meeting was launched, and since then, every 5 years, we have repeated the world meetings. The focus of world meetings is mainly to recap the state of the art in different areas of pulmonary hypertension, elaborate both basic science and clinical recommendation, and propose future research strategies in this field.
This is very interesting indeed, and very important to state. So for our readers who are very interested indeed by pulmonary hypertension, how do you compare the World Symposium proceedings and guidelines such as the European ESC, ERS guidelines published in the European Respiratory Journal and in the European Heart Journal in 2015?
Thanks, Mark. There is an important distinction between the proceedings and guidelines. Proceedings are elaborated by a task force and they propose papers, traditional papers with general recommendations, while the guidelines are proposed by task forces nominated by scientific societies with the objective to propose a more formal recommendation graded with a specific and uniform system. The proceedings follow the traditional review process of the regular papers, while the guidelines are reviewed more formally by a larger group of reviewers from different expertise areas and different countries, and the revision time is much longer. At the end of the day, there are similar information in proceedings and guidelines, but the guidelines are more formal, provide more formal and graded recommendations.
Thank you very much. So there is a very clear complementarities between the two exercises, and it's very, very interesting to hear. So let's go now to some of the very important take-home messages from the proceedings. And I would like to start with asking what are your take-home messages on the hemodynamic definitions of pulmonary hypertension?
This is one of the most important proposals of the current proceedings. And for me, there is a warning that the negative influence of an increase of pulmonary arterial pressure may start before the threshold that we used in the past of 25 millimeters of mercury. In fact, starting from 20, and in particular, if there is also an associated increase of PVR more than 3 good units, in some type of pulmonary hypertension, there is already an increase of mortality. And this currently has not any treatment consequence, because we have not studies with assessing drugs in this range between 20 and 25, but solicitation of more outcome studies trying to detect the outcome of this new range of pulmonary pressures.
Thank you very much. It is indeed important to indicate that we have now rigorous cutoffs of the upper limit of normal of mean PAP based on evidence. And I think you have made it very clear that it will translate certainly into very important consequences. And it's an important decision from the World Symposium to have put this hemodynamic definition in the spotlight. So we have also in these proceedings a very important chapter you led with Valerie McLaughlin on risk stratification and treatment. In the European Respiratory Journal, in the European Heart Journal, in the last couple of years, there have been some very important articles published on risk stratification. And it appears that risk stratification in pulmonary arterial hypertension, in PAH, is of major importance. It has also translated into an influence in the treatment algorithm published in the proceedings under your leadership. So can you comment on that, please?
Yeah. So in a period of absence of new approved medications, in particular of medication acting of novel pathways, we have tried to optimize the available medication, the available use of the medication according to the patient severity, based on the stratification of risk, having as objective a low risk profile. And this strategy has proved to be favorable, because there is a concordance of different registries that this type of risk stratification, and in particular having as goal the low risk profile, this provides an improvement of the patient outcome. So refining the strategies of what we have is a substitute in some way of novel medications.
Thank you. It is indeed a very important decision from the task force you led, and this chapter is really interesting and will certainly allow future improvement in the management of patients with PAH. So currently, as you state, all approved PAH therapies target the endothelin-1, the nitric oxide, and the prostacyclin pathways. In the recent years, there were several randomized controlled trials testing new agents outside these three pathways, but they all have failed in the last few years. Is it because these pathways were not relevant, or because traditional clinical trials design are not adapted to drugs which may not be vasodilators?
Probably both aspects may play a role, including also the favorable effect of the background therapy, which raises the hurdle to new compounds to show efficacy. I believe that we cannot go back from a morbidity and mortality primary endpoint. However, we can also add additional parameters assessing clinical and structural improvement. This will lead to longer studies, because to show improvement, to show structural reverse remodeling, it will require more time. However, I think we have no other ways to test new proposed medications interacting with novel pathobiological pathways.
So, Nazzareno, let's move to the most common causes of pulmonary hypertension. Indeed, pulmonary hypertension due to left heart disease and chronic lung disease are very common. And many people wish to know the expert opinion on should we treat these patients with drugs approved for PH? What is the proceedings and what is the task force conclusion on that topic?
Yes. So in the past few years, multiple studies have been performed in these two areas, utilizing the drugs approved for Group 1 PAH, but unfortunately without achieving convincing favorable results. On the contrary, there are signals, there are red flags for detrimental effect. So probably we need to rethink our strategy in these two fields. Maybe we should utilize different strategies because apparently in these two different fields we are utilizing the same drugs. Probably we need to rethink the strategy, likely adopting innovative proposals. I think our energy should be devoted to these patients because this is clearly a gap of treatment. There is a gap of treatment, a gap of evidence how to best treat these patients with very, very poor outcome, but probably with innovative proposals.
Okay, that's I think also an important take-home message from the task forces. There was, however, an important topic with impressive improvements since the last World Symposium. Indeed, in chronic thromboembolic pulmonary hypertension, there were many important discoveries which translate into better outcomes in our patients. So what is your take-home message for multidisciplinary management of CTEPH in expert centers?
Yes, this is probably the most interesting field to date. We have already experienced the revolution of the so-called heart team, joining cardiac surgeon, interventional cardiologist and clinician to decide for a patient if it's appropriate to use surgery or intervention or drugs. And now we have the pulmonary vascular team for CTEPH patients because we have demonstrated efficacy of endarterectomy, the gold standard for treatment, and now we have also balloon pulmonary angioplasty, we have drugs. So the pulmonary vascular team, including cardiologists, pulmonologists, cardiac and thoracic surgeons, radiologists, anesthesiologists, is absolutely needed in expert centers to define which is the treatment most appropriate for the individual patients, and also to combine treatments in hybrid strategy, which is the novel approach and which has led to the improvement of survival. Group 4 PH is the group of patients with the best survival as compared to the other groups due to all this improvement and these new techniques.
That's really good to hear, and it really underscores the achievements of our community. And I really think that chronic thromboembolic pulmonary hypertension is an example, and we should all consider being very innovative in your management of different causes of PH. So that's really an important take-home message once again. So to conclude, the importance of patient perspectives in pulmonary hypertension has been emphasized in the World Symposium with an entire task force devoted to that topic. Could you share with us your vision of the partnership between pulmonary hypertension experts and patient organizations?
Yes, as you know, in the Sixth World Symposium in Nice, we gave the floor to patients since the beginning in the opening ceremony, and also the last task force to present their proposals was the task force of patients. I think we need to receive their messages. The patients do not want to talk only about symptoms, hemodynamics, biomarkers, survival. They want to be informed, they want to be involved in any decision in the diagnosis process, along the diagnosis process, and they outline the delay in the final diagnosis. Also, they want to discuss about treatments. They want to get informed on all available treatment and share with us any decision. In a sentence, they want to be at the center of the processes, and this will improve their psychological conditions, their social status, and facilitate also the most important alliance in this field, which is the alliance between patients and the physicians to improve the patient's care.
This was, I think, a very important, once again, decision of the World Symposium members to welcome very nicely the patients and their families, and they were indeed at the center of this meeting. So thank you very much, Nazzareno, for these important comments and for choosing the European Respiratory Journal for this important publication. This was Marc Humbert, section editor of the ERJ, discussing the proceedings of the Sixth World Symposium on Pulmonary Hypertension with Professor Nazzareno Galiè from the University of Bologna. Thank you very much, Nazzareno.
Thank you, Marc.